Hello everyone, my name is Ashley Alvarez, and then today I'll be sharing my project on the importance of discharge planning management, a topic that I am passionate about both as a medical assistant and as a nursing student. Here's the agenda for today's presentation. I'll begin with an introduction and explain why discharge planning is such an important issue. Then I'll provide some background and describe the problem as it appears in both research and practice. After that, I'll review the evidence that supports nurse-led discharge planning, outline the specific of my objectives of my project, and explain the methodology and intervention. I'll also go over the evaluation plan and expected outcomes, and then I'll finally close with a key implication and a personal reflection. This structure will help us move step by step through the project. Hospital discharge is one of the most vulnerable times for a patient. Without proper planning, and many face medication errors, unclear follow-up, or preventable complications that often brings them back to the hospital. Poor discharge planning also increases healthcare costs. Nurses are in a unique position to close these gaps by providing structured education, ensuring continuity of care, and empowering patients to manage their health. The purpose of my project is to highlight how nurse-led discharge planning can improve outcomes and reduce readmissions. In my outpatient cardiology role, I often see patients return with complications that could have been avoided with stronger discharge planning. For example, I recall a patient we had a cardiac stent placed, but was never educated on the importance of Plavix prescription. He came back within a week with chest pain caused by resistant stenosis, a completely preventable complication. More recently, during my clinical rotations, I also observed a surgical patient who tried to schedule a follow after a syncopal episode, but was told he had to wait for the hospital records to be reviewed prior to scheduling an appointment, with no timeline provided. Situations like this emphasize dangerous gaps in continuity of care and why discharge planning is so critical. Research supports what I observed in practice. A Cochrane review of 33 randomized controlled trials with more than 12,000 participants found that a personalized discharge planning that included discharge plans tailored to each individual patient's health and social care needs before leaving the hospital improved their outcomes compared to routine non-tailored discharge care. This study design included randomized trials of hospital inpatients grouped by patient type, older patients with medical conditions, people recovering from surgery, and mixed diagnosis. At the end of the study, it was found that individualized discharge planning shortened hospital stays and reduced unplanned readmissions. While the evidence remains strong, challenges remain. A randomized trial in Jamal Internal Medicine tested a transitional care program to reduce 30-day unplanned readmissions or death in 1,386 high-risk patients across 4 Swiss hospitals. The intervention combined medication reconciliation, teach-back education, a primary care follow within 7 days, and phone calls at days 3 and 14. Within 30 days, unplanned readmissions or death occurred in 21% of the intervention group versus 19.3% of controls, a non-significant difference. Readmissions alone were similar, while mortality was slightly higher in the intervention group. The program did not reduce those readmissions or improve other outcomes, highlighting the challenge of lowering earlier hospital returns. At the same time, an article provided by the Journal of Nursing had explored the risk factors for high-risk adverse events in elderly patients, had reported in their systematic review that nurse-led discharge planning interventions constantly reduce readmissions rates and improve continuity of care. Using observational design, researchers followed elderly patients after they left the hospital and analyzed medical records, functioning status, medication profiles, and social supports to identify the predictors of poor outcomes. The authors in the study concluded that recognizing these factors risk factors can help nurses and care team target follow-ups and transitional care services to the most vulnerable older adults, potentially reducing preventable readmission and other serious events. The project is guided by 4 main objectives. Within 6 months, I would like to aim to implement a structured nurse-led discharge education program for surgical patients and other patients as well. The goal is to reduce 30-day hospital readmissions by 15% compared with patients receiving standard instructions. Another objective is to improve medication adherence by 20% within 2 weeks of discharge, which will be measured through follow-up phone calls. And finally, we will evaluate patient satisfaction and aim to increase positive ratings of discharge process using post-discharge surveys. These objectives are both measurable and patient-centered. The methodology involves a nurse-led discharge plan with 4 main components: medication reconciliation, education using the teach-back method, and tailor written and verbal instructions, and follow-up phone calls at 72 hours and again at 14 days. Nurses will be trained on the protocol, and the program will be piloted on a surgical unit before expanding further. To address these barriers, discharge coordinators will help manage time constraints, plain language and visual aids, will support patients with low health literacy, and collaboration with outpatient providers will ensure smooth care transitions. To measure the effectiveness, the project will evaluate 3 outcomes. The primary outcome will be 30-day hospital readmission rates, tracked through electronic health records. Secondary outcome will include medication adherence, measured through patient self-reports and pharmacy refill data, and patient satisfaction, measured by standard surveys. Pre- and post-intervention results will be compared to determine the impact. Ethical consideration will be addressed with formal consent and patient confidentiality maintained throughout the process. I expect this intervention to lower 30-day readmission rates, improve compliance to prescribed medications, and increase patient satisfaction with their discharge process. These improvements can reduce unnecessary hospitalization, lower healthcare costs, while also promoting safer patient transitions. Importantly, the project also highlights the leadership role of nurses in driving evidence-based quality improvement. If successful, this model can be expanded across healthcare systems to strengthen and discharge planning and transitional care. In conclusion, this discharge planning is not just a step at the end of hospitalization. It is a vital process that shapes recovery and long-term outcomes. Nurse-led discharge education has the potential to reduce complications, prevent readmissions, and empower patients to succeed in their care at home. For me, this project is not only supported by research, but also by personal experience. I've seen too many patients come back with preventable issues due to poor discharge planning. These experiences inspire me to advocate for stronger systems that place patients at the center of care. So I thank you for your time for listening and hope we can better improve the system.